sir. So, Dr. Soumya wanted me to talk on optimizing biometry to avoid refractive surprise. No financial interest. So, what exactly is the biometry? It is a measuring of various dimensions of the eye, its components and their interrelationships using data to determine the ideal intraocular lens power. So, meter, autokeratometer, even keratometry can be incorporated into the IOL master or lens star, or even you can get the keratometry from the topography, whether it is a placido based or elevation based maps. So coming to the manual keratometry we used to do in our time like 30 years before, the principle is simple. It's on the fixed object and the variable image size with a fixed image and the variable object size. So the most common one is the Gaussian lamp one. So coming to the autorefractometer. So the keratometry in autorefractometer also very accurate because it measures the 3 mm zone. What exactly is the principle? It focuses the reflected corneal image onto an electronic photosensitive device which instantly records the size and computes to the radius of curvature. So axial length, coming to the axial length measurement, you can do with two equipment, either with the optical or with the ultrasound method. So coming to the ultrasound A scan, most frequently done by all of us, the principle is ultrasound probe has a piezoelectric crystal that electrically emits and receives the high frequency of sound waves. So normally what happens, the measurement is from the anterior corneal surface to the internal limiting membrane of the retina. So if you make a 1 mm error, that means there is an error of 2.5 diopters post-operatively. You have to be very, very careful, and 50% of the surgeons post-operative surprise is a scan error. So what are the tips for accurate axial length measurement using this method? First, make sure that machine is calibrated very well. Always you should look for the echoes from the cornea, anterior lens, posterior lens and retina should be present in a very good amplitude. Normally average of 5 to 10 are most consistent result giving a lowest standard deviation. So average has to be between 5 to 10. Misalignment along the optic nerve is recognized by always a absent in the scale spike. So if you can see here, A is the initial spike where probe tip and the cornea, B is the anterior lens capsule, C is the posterior lens capsule, then retina, sclera and F is the orbital fat. So what are the uses of gain in difficult situation? So especially you have to increase the gain whenever there is a dense cataract. So when you do with the dense cataract, you increase up to 100%. Or you have to decrease the gain whenever you are doing a biometry in a silicon filled eye. So you have to ask the patient whether they are operated for retina surgery or not. So coming to the most accurate ultrasound method is the immersion technique. Normally patient has to be in the supine position, or even you can perform with the standard ophthalmic chair that is reclined at 45 degree, normally by the help of positioning shell or Prager shell. So what are the limitations of this immersion you have to do? I think everybody will tell you do immersion, but you have to be very important. The study shows that when you take an 18 out of 34 sample, there are positive organisms grown in this positioning or Prager shell. So you have to be that sure. So the best recommendation, this shell and the probe should be soaked in alcohol or hydrogen peroxide for at least for 5 minutes. Then you have to allow it to keep it for dry, then flushed with a BSS solution. This is very, very important for prevent any of the infection to happen. These are the difficult situation when you are doing with ultrasound. That is in the case of low vision, patient with nystagmus, blepharospasm and strabismus. So one or two point about the posterior staphylococcus, because it has got a irregular shape of the ocular wall. So when you are doing the scan, normally you will have a high retinal spike. The deepest portion of the staphylococcus may be located eccentric to the macula. So thus the measurement may be longer than the true axial length along the visual axis. This is very, very important when you are dealing posterior staphylococcus. I do remember I did a scan with the posterior staphylococcus. In spite of optical biometry, I have to reoperate 2 times. So as I said that silicon oil, you have to decrease the gain. So let me come to the optical biometer. These were the initial optical biometer, that is, so IOL master was the first optical biometer 500, which is based on the partial coherence interferometry. Later comes the lens star based upon the low coherence optical reflectometry. Basically in the IOL master 500, number of points tested are 6 points, and in lens star it used to test around 32 points. So compared to the IOL master 500, lens star was better. But now comes the latest one, is the IOL master 700. The basic principle itself is different. It is based on the search source OCT. So it gives a much better result because it measures the axial length along almost in 0.4 second, and designed to measure the axial length along the visual axis. It also uses the lateral slit illumination of the crystalline lens and the cornea to determine the antechamber depth, and autokeratometry to estimate the corneal curvature. But very important, it also measures the posterior corneal curvature. If you see, I think what are the machine which really measure the posterior corneal curvature, you use the accurate biometry because of most of the new IOL formulas which is with the posterior corneal curvature. So you need to look for equipment which can even look at the posterior corneal curvature. So these are the advantage, especially because of when you are doing with a very thick PSC and all, IOL master 700 bypasses over IOL master 500 or even over the lens star. But there are limitations with IOL master 700 also, that patient has to look straight. Whenever it even takes in a mature cataract, with a very dense mature cataract grade 4, sometimes it will not measure. But of course it is very expensive, you have to keep it in mind, it is almost double the money. So let me come to the one or two word about the IOL formulas. The first generation or the SRK1 beginners, second generation then becomes the SRK2, then third generation has become like SRKT, Holiday and Hoffer Q. Now we are with the fourth generation, Holiday 2, Aegis and also Barrett's 2 formula. So normally this theoretical formula based on the mathematical principle revolving around the schematic guide. Then comes the regression formula which is working backwards on the post-operative outcome. But this third and the fourth generation is a mix and match of both theoretical and regression formulas. So coming to the one or two word about the SRK formula, which gives a good results between the axial length between 22 to 24.5, because normally it works well within this range of 22.5 to 26, because they normally A constant computed based on the average axial length of 23.5. This is my assumption. So this is about the SRKT formula. Normally Holiday 1 works on the surgeon's factor, Holiday 2 on the ACD, Hoffer Q on the pseudophakic ACD. So Haig's formula most useful in the long eyes. Coming to the Holiday 2, most of us been using most sophisticated formula because of these reasons. It takes 7 parameters into account. One is axial length, AC depth, central corneal power, lens thickness, white to white, age of the patient and the previous refraction. But you have to keep it in mind about the effective lens position. So as you know that in any dual system, if the primary lens and the distance of the screen are fixed, then the effective power of the system will be depend upon power and the position of the second lens. This is also very important. What are the factor affecting effective lens position is axial length, limbal white to white, pre-op ACD, lens thickness. I will not be talking much about all these formulas. Special case, post-refractive surgery AL power calculation is also very important. But I don't have much problem with this. But since those are doing with the ultrasound, you have to log into the universal Barrett 2 formula, put the preoperative this keratometry reading, then you can come out with a very good result. But now most of the formulas like coming in the IOL master 700 only, post refractive, go to that formula, then you will get the power straight away. So one more last word about the toric IOL calculation. Whenever you are doing BPs, I am telling you, whenever you are counseling the patient, look at the keratometry reading, you talk to the patient. The treating astigmatism is very important. Patient will not be happy more than one diopters of astigmatism. You have to give all patient option to get rid of their astigmatism, whatever the residual level in the cornea. So if the patient is not affordable, then up to your call, but astigmatism control is so important. In conclusion, due diligence has to be undertaken during the biometry to prevent post-operative refractive surprises. A proper history and use of optical biometry and specific formula is at most importance. In customization of cataract surgery, biometry is very important. Once again, I thank Soumya and the whole KSOS for this opportunity. Thank you one and all. So we just keep discussion because biometry is so important. Normally when PGs and all the fellows join to us, they make a mistake. In the end, we have to face the music when the patient comes to us with them. There are some cases which is unavoidable, like posterior staphylococcus. We have to tell the patient about the guarded visual problem. But biometry has to be that good. Of course, if you have got a very good optical biometry, almost 700 or any of the hair and biometry, then I think you can offer a very good premium lens to the patient.